Hello, good morning. My name is Titus Kamal. I'm a nurse working at Nanyuki Sim Hospital at the emergency department and also simulation facilitator. Today, we are going to demonstrate assessment and management of a patient in sepsis. Our objective in this simulation will be 1, to demonstrate the A2E assessment of an acute unwell patient. 2, to identify the key signs and symptoms of sepsis. And 3, to correctly apply the algorithm in the management of sepsis. This one, we're going to carry it in a safe space. And what do you mean by safe space? Safe space in the aspect that we have a room to make mistakes, correct our mistakes, improve on our mistakes, without causing any harm to our patient. Because in this scenario, you're going to use a mannequin. And whatever you're going to do will mimic exactly what we are expected to do in a real life situation. In order to achieve that, we are going to bring the concept of fiction contract. So whatever we are going to do here is the same thing that we'll do in a real life situation. With me, I have our Dr. Amanda, who will learn the simulation together. Good morning, Dr. Amanda.
Good morning, Titus.
I have John here, and John reports to me that he has been having a 3-day history of painful urination, low back pain, and today he says that he is feeling unwell and he has never been sick before. He's 41 years old, and I would love if you can assist me to assess him and we manage him and see what he might be having.
Okay, so John, a patient who has had 3 days history of painful urination and low back pain, and has reported that today he's been feeling generally unwell, has not been sick before.
Yes.
Okay, this is John.
Okay.
John?
Yeah, John is able to talk to us. Yes.
Okay. So if John is talking to me, his airway must be patterned. So I'm going to assess his breathing next.
Okay.
I'd like to get his SpO2, checking for the saturation.
We have saturations of 93.
Because I'm aiming for 94, I'm going to give him supplemental oxygen before I continue with the rest of the assessment. So, next I'd like to examine his chest. John, is it okay if I open you closer to
Yes, okay,
examine your chest? So next I'm checking for the respiratory rate. I'm counting per minute.
We have respiratory rate of 26.
26 is quite on the higher side. I'd love to also know, is the chest rising and falling symmetrically?
Yes, the chest is rising and falling symmetrically, and we don't have any signs of respiratory distress.
Alright. So I'd like to auscultate his chest.
Okay. Clear. Good entry. Clear. Clear.
Okay. I'm comfortable with B. Next, I'm going to check for John's circulation.
Okay.
I'll start by checking if there's a temperature gradient.
Yes, the hands are cold. They are cold.
Okay. Next, I'll look for his peripheral pulse. I'm counting.
In 1 minute, we have a pulse of 132 beats.
Okay, 132 is quite on the higher side.
Yeah.
Before I move on, I'd like to check his capillary refill time. Kenyatta 1, Kenyatta 2, Kenyatta 3, Kenyatta 4, Kenyatta 5.
4 seconds.
4 seconds is also on the higher side.
Yeah.
So I'd love to get his blood pressure.
Okay.
But I'm already thinking he will need IV cannulation.
Okay.
So checking the blood pressure.
So we have blood pressure of 76 over 51.
Okay, 76 over 51 is on the lower side. What I'm going to do, I'd like to cannulate John.
Okay.
So I'm putting a large bore IV cannula. IV access is in. Getting blood samples for a complete blood count, a renal profile, serum lactate levels, as well as blood culture samples. Sending those off to the lab. So John presented with a history of painful urination for 3 days, and he's presenting with features of shock. So I'm thinking he might have septic shock. First, I'd like to give him broad spectrum antibiotic.
Okay.
So I'm giving IV ceftriaxone 2 grams.
Okay, fine.
As well as starting him on a crystalline fluid. So we'll start with 1 liter of ringers or normal saline, whichever is available. We have ringers.
Okay.
So 1 liter of ringers is running. And I'll continue to assess his disability.
Fine.
So, John?
Yes,
Okay, John is alert. I'd like to get his blood sugar.
his blood sugar is 6.1.
6.1 is normal. So, I'd also want to check his pupils and see if they're equal.
Yeah, equal.
And if they're reacting to light.
Yes, they are equal to that.
Alright, perfect. So, next I'd like to expose John and check for everything else.
Okay.
So, I'm opening his clothes up.
Yeah.
I'm checking for any rashes,
You don't have any rash.
any bleeding.
No bleeding.
Is there any signs of trauma?
We don't have any sign of trauma.
Okay, perfect. So I'm getting his temperature as well.
34.9.
34.9 is quite low. So we'd like to cover him up with a blanket
Okay.
and get a heater ready.
Fine.
Okay. So now that we are giving some fluids, I'd like to reassess John and see how he is. So I'm going to reassess the patient. John,
I don't know, he's not alive. He is on phone, he's responding.
okay, if you can talk to me, his airway must be okay.
Yeah.
So I'll move to assess his breathing.
Okay.
I'll recheck the saturation levels.
Now on oxygen, we are having 96.
96 is okay. Next, I'd like to examine his chest. If there's any changes, any features of respiratory distress.
No features of respiratory distress.
Okay. How is the chest rising and falling?
Yeah, equal symmetrical.
Okay. And what is the current respiratory rate?
Still remains 26.
Okay. Next, I'd like to auscultate his chest.
Okay. Good entry, good entry, good entry, good entry.
Okay, good. Since the oxygen helps, the circulations have come up. So next I'm going to assess his circulation.
Okay.
I'll start with checking if the hands are still cold.
Still cold and crampy.
Okay. How is his peripheral pulses now in terms of the character?
Still weak.
Okay.
Pulse of 136 now.
Okay. 136 is still on the higher side. How is his blood pressure now?
He has He has blood pressure of 72 over 44.
72 over 44 is still low, despite running the fluids. So we're starting on another bolus of Ringer's lactate,
Okay.
and the fluid is running.
Okay.
I'd also want to check his capillary refill time. How is it now? 1, 2, 3, 4, 5.
4 seconds.
4 seconds is still on the higher side. So we have taken some samples to the lab. Do we have any results?
Yes, I have the results. You have lactate of 7, raised WBC, normal HB, normal renal profile.
Okay. Because he has a raised white cell count and lactate of above 2, and he seems to be hemodynamically unstable, I think John might be having septic shock.
Okay.
Because I'm suspecting septic shock, I'm going to also place a urinary catheter to monitor the urine output of the patient. As the second bolus of fluid is running, I'll reassess his cognitive state and see if he's alert. Is John alert? John?
No, John is not alert. He's only responding when we call him.
Okay, so that's at V, which means his condition might be worsening. How is the sugar currently?
Our sugar is 6.7.
6.7 is okay. Is there any changes when I expose John and check for any rashes?
No rashes, no changes.
No changes?
No changes.
Okay. So now that we've run a second bolus of fluid, I'd want to reassess John and see if his condition is improving. Okay, so John?
Yes, still not alert. He's only responding when you call him.
Means John's airway must be here. So let's assess his breathing and see what's the current respiratory rate.
Now, respiratory rate at 30.
30 is still high. Let's check for our saturations and see if there's any changes there. What's the current saturation?
On oxygen, he's saturating 96. Nice. Yeah.
96 is fine. Does he have any features of distress?
No features of
The chest is rising and falling symmetrically?
Yes.
Okay. I'm auscultating John's
Clear.
lungs.
Clear.
That's good. Okay. So next I'd like to check for his circulation.
Okay, fine.
So I'll start by checking the capillary refill. Kenyatta 1, Kenyatta 2, Kenyatta 3, Kenyatta 4, Kenyatta 5.
4 seconds.
4 seconds is still high. Is there any temperature gradient?
Yes. Cold and still calm.
Okay. How is the peripheral pulse in terms of rate and quality?
Still weak at 140.
140 is still high. And we've already given 2 boluses of fluid currently. So it might be time to scale up. Let's check his blood pressure and see what that looks like now.
76.35.
That is still quite low. So because we've already given fluid, I think it's time to move to vasopressors and call the critical care unit so that we admit him to the ICU. Do we have any adrenaline available?
Yes, we have adrenaline, 1 milligram and 1 milligram.
Alright. So considering his weight, we're going to calculate and see what his weight is and calculate at a rate of 0.05 micrograms per kilogram per minute as an infusion and keep reassessing him to see how he's doing.
Okay.
So next I'd like to check his alertness. How alert is John?
He's not alert, only responding when the body.
Okay. On exposure, any changes?
No change.
Okay. So I'd love to make the call to CCU now and brief them on John's status. So I'm going to place a call to the ICU to let them know that we have a patient covering.
That's okay.
Hello ICU. I'm Dr. Amanda calling from the emergency department. We have a patient here who is in septic shock and is hemodynamically unstable. This patient presented with a 3-day history of painful urination, low back pain, and has been generally unwell for a day. So when we assessed the patient, his saturations were at 93. We supplemented his oxygen levels. On his breathing is normal. However, his circulation, he had cold, clammy hands and a weak peripheral pulse and BPs of 78/46. We've already given him 2 liters of Ringer's lactate as a bolus, but he was unresponsive to the fluid. So we started at adrenaline 0.05 micrograms per kilo per minute. We're targeting a MAP of 65. In addition, we gave him 2 grams of IV ceftriaxone and placed a urinary catheter to monitor his output. So we also ran some blood tests for him and his lactate came back at 7. He also has a raised white cell count and his renal profile is normal. We'd like to have him admitted in your unit for IV antibiotics and the adrenaline infusion as we target the MAP of 65 as well as close monitoring. So we just demonstrated the assessment and management of a patient who was in septic shock. Using the systematic A to E approach, we were able to pick up that the patient required oxygen. We were able to pick up that he was hemodynamically unstable, for which we gave the IV fluids in a prompt manner. And once we were able to identify the septic shock, we also administered the IV antibiotic and sent some samples out to the lab. So when managing similar patients, the key points to remember is number 1, prompt identification and diagnosis of such patients. Prompt initiation of management, so antibiotics should be given within the first hour, supporting the hemodynamic status by giving IV fluids and moving to vasopressors if the IV fluids, if the patient is unresponsive to the fluids, and also continuous monitoring of the patient to ensure the management is up to par. For example, monitoring the urine output and also monitoring the blood pressures and the MAP to see how to titrate the vasopressors, for example. And another key point to remember is how to escalate similar patients to the relevant units. For example, the ICU, or if in a rural setting, making sure they reach a facility that has an ICU.